Thank you for viewing our webinar titled Healthcare Has Changed, Winning the Quality Reimbursement Game. It's brought to you by Q-Centrix. Q-Centrix uses market-leading technology coupled with the industry's largest and broadest team of nurse-educated quality information specialists to offer registry and core measure abstraction, concurrent review, infection control, and readmission risk solutions. We recently launched the only healthcare quality information system, QF, to allow hospitals to be prepared to succeed no matter what comes next in our industry. If after viewing the webinar you have questions, please feel free to reach out to our panelists. We'll share their contact information with you at the conclusion of the presentation. You may see our infographic about the reimbursement game. At Q-Centrix, we have a unique perspective on what contributes to the success of an organization relative to reimbursement. There are many factors involved, but we believe that the main contributors to success are technology, workforce management, and changing policy. Put in the context of the game, it's the strategy or approach you use, your player or players, and your understanding of the rules of the game. We've assembled 3 experts to talk about each of these very important topics. I'd like to tell you a little bit about each of them. Russell Reese is our Vice President of Technology. Russell has built and maintained various groundbreaking technologies. At Q-Centrix, its most recent development was QApps. As I mentioned, it is the only healthcare quality information system in the market. Prior to Q-Centrix, Russell developed the first dashboard technology for concurrent review of hospital patient files. Next, you'll hear from Gene Freeman, our VP of Client Services. Gene manages a remote workforce of more than 600 quality information specialists dedicated to improving quality outcomes. Prior to Q-Centrix, Gene promoted the use of quality improvement methodology to improve outcomes for Texas and Ohio regional hospitals while working for their state QIOs. She was instrumental in developing concurrent intervention model used to assist hospitals in impacting performance on core measure indicators while the patient was still in the hospital, and even served as a quality coach for process improvement projects within medical practices. Last, Brian Foy, our VP of Product Development, will explain some of the more important market items and even give a little insight on some primary research we conducted at the end of last year. Brian spent most of his career with strategic accountability for software applications in the HIT space. At TransUnion Healthcare and later at Altegra Health, Brian led a healthcare analytics application through an acquisition while overseeing the addition of key quality reporting and care management features. At Blue Cross Blue Shield of Illinois, Brian oversaw the implementation of a care and condition management reporting system to fulfill a key gap in that company's care management product offering. And now, let's start with Russell.
Thanks, Kristen. My name's Russell. As Kristen mentioned, I'm the Vice President of Technology here at Q-Centrix. I've been working with healthcare quality technology since Q-Centrix started about 5 years ago. And, a lot has happened in that short amount of time, but I want to start out a little bit earlier. So most of you know this, but it's worth remembering that medical records actually began as a tool for physicians. So I like to think about the original medical record as sort of like a journal. Physicians, they use it to jot down learnings, record what they'd seen for future reference, just generally to improve upon their skills. But it wasn't really until the 1920s, that hospitals started using medical records generally. And then in the 60s, the concept of electronic medical records was established. And then for a really long time, basically nothing happened. And separately, due to a different reimbursement model, the rest of the world developed electronic records much more quickly than the U.S. In fact, we didn't really make progress here in the U.S. until the HIPAA and HITECH Act set standards for the adoption of electronic medical records, and later reimbursement was established for having these records. So now we have technology in place to track patient records, to track the care given to patients, and even in this ideal world, the outcome of care. But what does that really mean? How should we report on patient data? How should we exchange that data? So let's talk about meaningful use as this top-down incentive that tries to answer these questions. You know, meaningful use generally is it's often the kind of the elephant in the room when you're talking about healthcare technology. But really, meaningful use is just trying to ask some important questions and incentivize hospitals to answer them. So, are you using your EMR for real data collection? Are you collecting the information you need to improve quality, to track patient outcomes? Are we using technology to capture and understand the data in the same way that other industries use technology? So, you know, essentially, are we using technology and our data to make our industry better? So meaningful use phase 1 is really kind of intended to help refine our processes. And then meaningful use phase 2 focused on outcomes. And now meaningful use phase 3, it's really kind of about simplifying standards with the goal of hospital providers connecting medical records together. So you can think about this evolution similarly to kind of the evolution of personal computers. You know, at first we had these kind of giant mainframes and they're built with vacuum tubes. You know, these monolithic systems that only few people can afford to use. Then everyone gets a PC. Meaningful use phase 2 is something like the PC era. So almost everyone can afford a computer, but they aren't really connected in a way that allows you to share information or knowledge. And meaningful use stage 3 is kind of what we have today. So we have the cloud, right? The value doesn't come really from the computer itself. It's more how you can connect it to other computers and larger networks around the world, and the lessons that we learn from analyzing all the resulting information. So meaningful use phase 3 wants us kind of at that point in healthcare. You know, it's kind of pushing us into this world that is a larger interchange of data. But, you know, of course, we're talking about patient data. It can't be public. We can't just share it with anyone. But we do want some exchange of this information. So with that said, let's talk about security. So, you know, as we think about this interchange of data, security becomes more of a prominent issue. And HIPAA set a minimum standard for the security of PHI. And later, the HITECH Act established standards for how we store PHI and how we transmit it. The task, though, of actually securing protected health information is only getting harder, even for the largest organizations. For example, in 2014, we had all these headline breaches at companies like JP Chase, Home Depot, Target, other retail and financial entities, but the healthcare industry actually accounted for 43% of all major personal information breaches. So that's nearly half. In fact, more than 30 million people were affected by healthcare data breaches in 2014. And the average out-of-pocket cost for a victim of medical identity theft is almost $19,000. So, you know, on kind of the flip side, the breaches are also costly for the healthcare system. A 2014 breach at CHS of 5.4 million records that included some personally identifying information, social security numbers, that resulted in $150 million in fines and security upgrade costs. And, you know, this might be surprising, but health records actually sell for $50 per record on the black market. By, you know, way of comparison, a credit card is just $1 in the black market. This year in 2015, it's estimated that breaches are going to cost the healthcare industry $5.6 billion. So, you know, obviously security is important, but we shouldn't be afraid to move forward with interoperability. You know, I really believe that long-term quality improvement depends on access to patient data and the ability to analyze that data and draw conclusions. That requires some openness. So what are the key considerations? Then let's turn to kind of what I consider to be the 3 top issues impacting healthcare technology. So the first I'll call secure access. This just means being secure while still allowing access. I just mentioned the importance of security in order to avoid a breach, but we don't want to make the system so secure that it isn't easily accessible if a clinician or someone else needs vital information about a patient. I mean, healthcare professionals need access to this data and they need fast access to it. one way to think of it is like this. So Amazon will remember you the next time you visit their site. And this seems like it might be insecure, and to some extent, it is. But Amazon ensures that actions like buying items, changing your contact info, et cetera, still require your password. And in fact, they're actually incentivized to work really hard to not only make it as easy as possible for you to buy things, but also for that process to be as secure as possible. Well, why? There's this tipping point where fraud hurts them just as much or more than losing a sale. So Amazon spends a lot of time, effort, and money trying to make their experience as user-friendly as possible while still being as secure as possible. It's definitely a balancing act. Now, imagine if using your EHR was as easy as buying something on Amazon, right? That would be amazing. The second issue I want to talk about is interoperability. So there are so many systems out there, and very few of them were originally designed with interoperability in mind. So, it's hard to take action in one system using data from another system without lots of manual work or data entry or something along those lines. That's somewhat complicated by industry standards where they do exist. Many systems either don't support them or they're not using the same version. So, hospitals might take additional steps to customize the standards to meet their specific needs, which then makes it more difficult downstream to reuse that same customized data source for another application. One example of this is HL7v2. So actually there's a version 3 that not really many hospitals are using. And so much time and effort was put into interoperating with version 2 and customizing it that the cost and effort of upgrading, it's just too much to undertake. And on top of that, any minor change to the feed is probably going to break something downstream, and you have no way of testing that ahead of time. Now there's a new standard, FHIR, that's getting a lot of buzz, and you can kind of see where this cycle is going. The last issue I want to talk about today is workforce management. So this third element is at the intersection of people and technology. Technology focused on process improvement and automation works best when you have a working process in place that you want to build around. So you already understand all the nuances, but you really need your team to be in order if you want to implement a technology. It's really hard to make it work in the opposite direction. There's this general idea that you can be a technology company and come into a hospital and have an out-of-the-box system ready to go live. Actually, there are a bunch of people that you need to train first, a lot of documentation to provide. Of course, you haven't really addressed the interoperability questions and potentially downstream interoperability. Too often technology doesn't really take these factors into account and paints a rosy picture of what it can do and how quickly it can do it. So when you're evaluating software, some specific considerations to think about include the amount of data captured and visibility into that data, the protection of data while still keeping in mind interoperability and some access, the future plans for the system or the company, for example, their product roadmap, and finally, ease of training and the availability of documentation for your team. So there's a lot to consider, really, but generally, I think as we get better at balancing the three overarching issues of secure access, interoperability, and workforce management, that really technology for healthcare is going to continue to improve and even become a joy to use. So, I'm really excited to see what happens over the next few years with Meaningful Use Phase 3, with those incentives, and just generally with cloud-based healthcare technology. It's definitely an exciting time to be working with healthcare systems. So with that, I'm going to turn it over to our workforce management expert, Gene Freeman, and we'll try to address any questions at the end as time allows. Thanks.
Thanks, Russell. Hi, everybody. This is Jean. Throughout my career, I've worked in the quality world in several different settings, including the hospital, physician office, managed health plans, and quality improvement organizations, all which use technology differently. I've certainly learned a lot about the importance of technology since joining Q-Centrix, as the company was just starting and now managing over 600 quality professionals that all work remotely. Technology is everything to our staff, from communicating with each other and our partners to working through a secure interface with the hospital EMR and vendor tool, along also with learning the documentation systems of over 300 hospitals. Technology is our connection. In the past, it was common for hospitals to secure technology that met the needs of some of the organization, but they weren't really aware of what was needed by all, including the quality department needs, because quality was often not at the table. What I often found in the hospital setting is that the quality department frequently was one person with an office in the basement and usually without a window. When I worked with the quality improvement organization for Texas and then Ohio, I met with hospitals around the state, working with them to improve their core measure performance. Before the risk of losing the APU was in place, it was a lot harder for them to get buy-in from executives and the rest of the organization to make technology system changes that ultimately would help improve their performance and then patient outcomes. These things are changing now. Quality is included at the table more frequently as EMR conversions are planned, and they have input on technology that will impact their core measure performance, ECQM submissions, and value-based purchasing. The quality workforce, along with everyone interacting with the patient from a technology standpoint, is evolving. Nurses haven't always been known for their tech-savvy abilities, but that's changing now because it has to. When I began abstracting and working with core measures, like many, it was an added part to my role. At the time, I was a case manager in the emergency department. I fit abstracting in between checking out admissions in the ED to ensure they met inpatient or observation criteria. During that time, I was known as a bird dog because they said I was always sniffing around, either in the ED or in the records abstracting. I had no training before starting abstractions. Quality was simply a slice of my time, so certainly it took me a lot longer to complete abstractions and understand everything. This speaks to the multitasking myth. Multitasking actually undermines efficiency. It leads to as much as 40% drop in productivity, increased stress, and a 10% drop in IQ. The reality is that when you have a group of people in your hospital doing quality part-time, it's hard for them to be at the top of their game. This many hat syndrome is consistent and common in registries, infection control, core measure abstraction, and the list goes on and on. As a nurse, I remember that splitting the time I dedicated to abstractions did not give me the efficiency that I needed. At a time when efficiency is an imperative for most hospitals, it seems the idea of wearing many hats is more and more common. It's a hard choice that hospitals are faced with every day. Many facilities have people in their organization doing data collection for quality that have other roles in which their time is better suited. There's an efficiency and value to precisely understanding the roles. There's always a trade-off, whether that's opportunity, cost, billing, patient satisfaction, etc. Through specialization and concentration of duties, efficiency is obtained. Stroke abstraction is an example of this. On average, our nurses take about 28 minutes to complete a stroke case. That's an average of multiple different variations of stroke cases we complete. Since it is an average, there are many that take longer than that to abstract. Based on our experience, nearly 15% of stroke cases take more than twice as long to abstract. This means that even the best trained nurses are only able to abstract 10 to 15 stroke cases each day. Stroke nurses see about 10 to 15 patients per day, meaning that each case that's abstracted by a skilled stroke nurse at your hospital is one fewer patient that can be seen by the nurse. This trade-off can often result in staffing challenges, reduced patient throughput, longer wait times for patients, and lower patient satisfaction scores. Hospitals have to determine if the trade-off is worth it while trying to utilize staff at the top of their license and experience. Gaining control over the variability of data is critical. If data collection is just a slice of the person's responsibility, there will be frequent interruptions, which impact consistency and outcome of the abstractions. In the area of data collection, the more often a record is started and stopped, it increases the potential for errors. There are many reasons other than that for variability. One is expertise. Does the person understand what they are looking for and the specifications of the elements? For example, a cardiac registry, cardiac surgery registry abstractor, they need to understand the cardiac anatomy to collect the data element information. Another reason is technology. Training on the use of the vendor tool. Are they understanding the medical record, the EMR use? And then another reason for variability is change, the regulatory changes, specification manual updates, coding instructions changes. The abstractor has to stay current. Variability leads to incorrect assumptions from the data. Therefore, not getting to the bottom of issues that need change. It also doesn't indicate the true performance of the patient care team. Now I'm going to turn it over to Brian Foy. Brian?
Thanks, Jean. As a reminder, please submit your questions via the WebEx functionality, and we'll address them at the end of the webinar. I'm going to talk now a little bit about the regulatory environment, specifically within the quality industry. And something we talk about with our partners all the time is just how the market is evolving now, but how it's evolved over the past 10 or 15 years. We've seen a lot of change, really starting with the IOM, the Institute of Medicine paper in 1999, to err is human. The thing we notice the most about what's happening in our industry right now is the pace of change. And not just with respect to the frequency of announcement or the changes, but really the impact or the stakes that are contained within those changes as well. It seems like we're getting announcements almost every week from CMS, but every time we see one of these announcements, the stakes are so much higher than they used to be. And so really the frequency of change has increased, and the stakes of those changes are also increasing. Something else we talk a lot about with our partners is just the fact that measures will extend beyond the inpatient realm. They will move to the outpatient, and frankly, we think that they will follow that care continuum as we continue to move services outside the four walls of the hospital. We encourage our partners to anticipate these changes because we think they're coming. And finally, another important observation that we make with our partners all the time is that this is no longer just the domain of government. Commercial payers are absolutely in the game. You see this with ACOs, and we'll talk a little bit more in a moment or two about HHS and bundled payments. The government is encouraging the adoption of the principles that they're memorializing in the Affordable Care Act and other legislation to take hold within the commercial space. We talk a lot about, a good example of this is in Michigan, where we're working with a large payer there. It's called the Collaborative Quality Initiative, and the payer is providing incentive dollars to Michigan-based providers that report certain measures. What's unique about these measures, obviously, is that they're different than the government's and they provide additional complexity. Not to mention the Payment Learning and Action Network, which we'll discuss in a moment. So recently, we've seen the announcement from Secretary Burwell and the Department of Health and Human Services regarding the Payment Learning and Action Network. This is effectively an innovation lab that the government is sponsoring to explore alternative payment methods. First, let's start with the announcement itself for what their ambitious goals are with respect to alternative payment models. And now I'm going to read from an op-ed here by Secretary Burwell in the New England Journal of Medicine. Reading now from the op-ed. Our goal is to have 85% of all Medicare fee-for-service payments tied to quality or value by 2016 and 90% by 2018. They go on to say that their target is to have 30% of Medicare payments tied to quality or value through alternative payment models by the end of 2016 and 50% of payments by the end of 2018. These numbers are easy to find. If you Google what's happening with HHS, you can find those numbers. What's interesting about this announcement is that they actually have a goal that they're moving towards to funnel reimbursement dollars through quality programs. It maybe doesn't feel impactful because of all the change that we've seen recently in the recent past with CMS, but this is actually a milestone for the government to have a goal of funneling payment dollars through a value-based purchasing paradigm. And so they've initiated this Payment Learning and Action Network, and they've actually gotten over 2,000 organizations to participate or sign up to participate. A couple of details about the organizations that have signed up. First of all, the private payers are on this list. Humana, Kaiser Permanente, Cigna, Aetna, HCSC. They represent more than 50% of the private health insurance market. Cigna has also indicated that they agree to the goals set by HHS. Notably, they'd like 90% of their payments in value-based arrangements and 50% of payments in alternative payment models by 2018. Particularly, Cigna has announced that they will focus on ensuring that physicians providing care to its most vulnerable and at-risk members have an incentive and assistance to provide high-quality, value-based care. States and municipalities are in on the action. The state of Delaware has set a goal of having 80% of that state's population receive care through value-based payments and service delivery models within 5 years. Health systems have also indicated they will participate. Organizations like Dignity, Ascension, Trinity, Aetna, and HCSC have indicated that they want 50% of their payments to accountable care by 2018 and 75% by 2020. Now let's talk about the CMS rule change in 2014. When the announcements were made last year that there would be several measures topped out, frankly, we knew that this would have an impact on our business, not all positive, but we still looked at it as an opportunity to reach out to the market and find out what our partners were going to do in light of this news, and even find out what facilities who are not affiliated with our business were going to do. And so we went out and surveyed the market, and we'd like to share some of that data with you now. First of all, we learned that agility is critical. Everyone we talked to didn't really understand exactly how the changes would affect them, and we know that it's really critical to be able to respond to these changes effectively. Now on to our results. Almost 60% of our partners said they will continue to abstract voluntary measures. We thought that was notable. We didn't expect the percentage to be quite that high. And what we found was that many of our partners have spent a lot of time and work and effort getting their organizations to manage those process measures effectively. They really looked at those measures as a rising tide that would raise all boats with respect to other quality measures. In fact, they felt that by continuing those measures, 57% of our partners felt that it would positively affect performance in other areas like readmissions, mortality, and efficiency. Another thing that we found when we surveyed our partners about the changes last year was that nearly 48% said that they viewed quality as a market differentiator. And so by having those measures, those process measures, they were able to differentiate themselves from their local competition. That also correlated to observations about registries and other ways to differentiate themselves from their competition. And finally, as you might expect, we asked customers what they would be focusing on this year, and you probably imagine what the top 3 items were. Readmissions risk, potentially preventable conditions, and infection control were all very high on our partners' lists when we asked about what they would be focusing on strategically this year. Finally, what have we learned? Based on our perspective, winning the reimbursement game depends on a couple of things. And we don't make light of this. By using this game metaphor, we're not making light of what's going on in our industry. But in fact, if you think about it as a game, there are some strategic correlations there on how to win. First of all, technology is very important. In addition to the investments that you must make in technology through meaningful use and other programs, you need to be selecting technology and technology vendors that are flexible, that can keep up with change, and can integrate with the other systems that you have. You will not be able to find one system to address all of your needs, and so the vendors that you do select and the technology that you do implement must be flexible. Second of all, it's very important to have a large and diverse workforce that can specialize. You need folks that can specialize in quality measurement, So the people that you deem necessary to do patient care can do patient care and remain at the top of their license. This is why it's effective to work with a vendor like us, because we can allow you that flexibility to specialize in quality measurement while your people can focus on high-value activities within the four walls of the hospital. Finally, as we've talked about a lot, the market is changing very rapidly. You need to be able to stay on top of how things are changing, how it's going to affect how you'll be reimbursed, and what's at stake. For all these reasons, this is why we've made investments in our own technology. We must accommodate our own workforce. We must be able to remain flexible to change. And Q-Apps allows us to do that, the market's first healthcare quality information system. We'd love to do a demo for you, so please reach out to us if you'd like to see that. Kristen?
Thanks, everyone, for viewing the webinar with Q-Centrix, the leader in quality data abstraction. We conduct in excess of 1 million quality data abstractions annually and are a comprehensive partner to hundreds of hospitals, providing clinical surveillance, abstraction, analysis, and improvement services. Please learn more by visiting www.qcentrix.com, or you'll see here the contact information for our 3 speakers. Please feel free to reach out to them individually. Thank you.